presentation on really peroneal tendon pathology. I mean, a lot of it's pretty straightforward. I'm sure you guys are very familiar with peroneal tendon pathology. Something I didn't really probably learn much about in school was peroneal tendon subluxation, nor did I probably really see a lot of it. I shouldn't say I didn't see a lot of it in residency, but I don't know if I was exactly in tune to looking for it at that time. It's something that's probably pretty easily missed. Injuries to the peroneal tendons can happen with lateral ankle sprains. Injuries to the superior peroneal retinaculum can additionally occur with lateral ankle sprains. They can be present with complaints of lateral ankle instability, deep ankle pain. So it's really easy to kind of look for the obvious things, ankle sprains, ankle instability. A lot of times the sensation of instability can be associated with a rupture of the superior peroneal retinaculum. And some other times it can be congenital as well, just based on the morphology of the fibula, which we'll go through. So one of those things just to kind of keep in mind if people aren't necessarily improving with, lateral ankle protocol for beefing up the ATFL, CFL. This is just another thing to kind of keep an eye on, because it can be easily missed by providers, surgeons alike. So just something to look out for. This is just a little bit about us. Just in case you guys aren't familiar with us. We have locations all over the place. I think there's 16 locations now, 18 doctors. We really do everything below the knee, so if you guys ever see something, you're not sure, you think maybe something was misdiagnosed by primary when it was sent to you, or, you have people who you're seeing for various complaints that, mention symptoms pertaining to the lower extremities, you can always give us a call or send them over as well. That is all of us. My locations, I'm mostly in Crystal Lake. I'm in Crystal Lake Monday, Tuesday, and Friday. I'm in Fox Lake Wednesdays, Lake in the Hills Thursdays. I'm from Wisconsin originally. I did my undergrad at University of Wisconsin-Oshkosh. Did my schooling at Scholl College of Podiatric Medicine at Rosalind Franklin over here in North Chicago. Did my training adjacent to the school in North Chicago at the VA, and then I just finished up a year-long fellowship with Northern Illinois Foot and Ankle Foundation in advanced foot and ankle reconstructive surgery. So getting into it, peroneal tendon anatomy. I'm sure. I think we have another person who's joining. So peroneal tendon anatomy: two tendons, peroneus longus and peroneus brevis. Obviously, sometimes there are accessory tendons, which we'll kind of get into a little bit. Accessory tendons and musculature, which can additionally cause problems and similar symptoms. They're really stabilized by the superior peroneal retinaculum, which I was talking about before. Other things that influence the stability of the peroneal tendons is the fibular groove depth, which maybe people don't necessarily talk about as much if they're less familiar with dealing with the peroneal tendons. Regarding peroneal tendinopathy, again, you guys probably see a lot of this. Overall, when we're talking about peroneal tendinopathy, we're talking about things like tenosynovitis, attenuation of the tendons, thickening of the tendons, tearing of the tendons. So a lot of this can be just from chronic overuse, chronic microtrauma, which can lead to degeneration and overall thickening over time of the tendons. It may involve tenosynovitis, like I said, fluid within the tendon sheath more than a physiological amount. A lot of times acute injuries can cause tearing. The peroneus brevis is notorious for kind of tearing as it courses posterior and inferior to the lateral malleolus. And I'd probably lump low-lying muscle bellies into peroneal tendinopathy. And then we're talking about things like peroneal tendon subluxation. It can be traumatic in origin from a sports-related injury, inversion injury, any run-of-the-mill lateral ankle sprain. It can cause disruption of superior peroneal retinaculum, which stabilizes the peroneal tendons posterior to the fibula. Another thing that I was speaking about is on the morphology of the fibular groove. It's supposed to be concave, creating a nice little area for the tendons to kind of live in and glide freely posterior and inferior to the lateral malleolus. But I've been noticing on MRIs, so a lot of these people with peroneal tendon subluxation, the morphology of the fibula sometimes, or the lateral malleolus, I should say, and the fibular groove is sometimes different, where it could either be flat or in some cases it's even convex, which really proves to be problematic in a lot of people. Now, I should say that there are people, and I've noticed people who clearly have subluxing peroneal tendons on clinical examination, but sometimes it's often an incidental finding as well, and it's really not symptomatic. Could it become symptomatic in the future? Possibly. Is it from a previous injury? Possibly. Because a lot of times if they're complaining of something else, we're not necessarily getting an MRI and evaluating the morphology of the fibular groove, so it's hard to exactly pinpoint the cause of it. Other things you can see, lateral ankle instability and subluxation in patients with like collagen disorders such as Ehlers-Danlos. This is just a little slide on anatomy. This is the distal fibula and really the lateral malleolus at the level of the ankle joint, where the brevis sits right behind the fibula in the fibular groove. And then the longus is behind it. I'll kind of go over a couple of MRI slides where we'll kind of discuss how things look on MR with peroneal tendinopathy. Most of the time, you're not going to see direct instability or subluxation of the tendons on MR because of the position of the foot, and it's not a dynamic study. But tendinopathy is really easy to see, and frankly, I see peroneal tendinopathy in a lot of imaging studies, whether or not that's actually the area of focus that we're looking at, just because that tendon, especially the peroneus brevis, like I said, how it sits just directly posterior to the fibula, and it has a tendency to kind of take a lot of wear and tear from being basically directly in contact with the bone. A really important aspect of the fibular groove is that, and some people don't know this, is basically a cartilaginous rim and a cartilaginous surface along the posterior aspect of the peroneal or of the fibular groove that allows the tendons to glide freely. Historically, people have kind of fixed peroneal grooves in a couple of different ways, one of which involves burring the posterior part of the fibular groove, which works, but it tends to burn off that cartilage, and it can, make the posterior surface of the fibula much more rough, which doesn't necessarily, provide a good environment for the peroneal tendons as they're constantly gliding against the back of the fibula. Things that can happen: cartilaginous rim can fracture off, seeing, avulsion fractures of the lateral malleolus and lateral ankle sprain. Sometimes you can see like a flex sign from a CFL injury. These are all kind of incidental things, or not necessarily incidental, but kind of additional things that you can see on some of these studies. So a lot of times what I'm trying to say is that people with lateral ankle pain and problems following an injury, especially, they kind of have, sometimes a number of things going on. So we're talking about peroneal tendinopathy versus peroneal subluxation. Typically with peroneal tendinopathy, it's gradual unless it's like an acute tear. I don't know that I've necessarily ever seen an acute rupture of a peroneal tendon. I think that'd be pretty unusual unless, I guess, it ruptured off the base of the fifth with an avulsion type fracture. But generally speaking, they don't really rupture posterior and inferior to the lateral malleolus. With peroneal subluxation, again, it can be gradual, over time following an injury that causes attenuation of the superior peroneal retinaculum. Otherwise it can often be sudden with an injury if the SPR is damaged, or there's some type of fracture injury to the lateral malleolus. Pain. A lot of times pain's in the exact same location for both. Again, posterior and inferior to the lateral malleolus, where the tendons course around. Peroneal tendinopathy pain tends to be dull versus sharp or achy, where a lot of times peroneal subluxation, especially in the process of its subluxing can be very sharp, very pinpoint. So it's usually, people present a little bit differently, or at least describe it a little bit differently. Instability, pretty unusual with peroneal tendinopathy, but not out of the realm of possibilities. Whereas, one of the key features of peroneal subluxation is inherent instability of the lateral ankle, not necessarily the lateral ankle ligaments, but that sensation of instability from the tendons kind of subluxing or displacing intralateral, around the distal fibula. Snapping, again, not usual with peroneal tendinopathy. In theory, there could be, suppose if there was some type of avulsion type fracture or cartilaginous injury on the posterior aspect of the fibula that kind of causes a snapping or popping as the tendons glide. But otherwise, people with peroneal subluxation often complain of snapping or popping of the ankle. So other things that people often complain with, similar symptoms of snapping or popping in the ankle, can be OCDs or osteochondral defects, which are often seen accompanied by or following lateral ankle sprains as well. Physical examination. Tendinopathy signs, direct tenderness to palpation. That's not unusual to subluxation either. Pain with resisted eversion or plantar flexion. Sometimes you see weakness, especially in cases of tearing or chronic attenuation where the tendons stretch out. Otherwise swelling, crepitus. Crepitus maybe not so much, but swelling often, kind of around the lateral ankle, which can be intermittent. On physical examination, signs of subluxation, again, snapping of the tendons or tendons rolling over the lateral fibular border. On circumduction, full range of motion of the ankle, or resisted dorsiflexion or plantar flexion with eversion. A lot of times when you maximally evert the foot and put it through dorsiflexion and plantar flexion, you can see those tendons kind of pop, snap over the lateral malleolus, just like I have here. So in this case on the left here, this is a picture I pulled from a textbook, but that would be an extreme case. A lot of times they look kind of like the one here on the right, but it's interesting when you put it through passive range of motion that the tendons kind of pop out, and that's usually when people complain of that really sharp pinpoint pain. Imaging modalities, obviously with any type of musculoskeletal injury, we usually start with plain radiographs to assess for fractures. When I'm specifically looking at plain radiographs, when somebody had come in complaining of a lateral ankle sprain or lateral ankle pain, things I'm looking at, the lateral malleolus itself, the distal tip of the lateral malleolus. Sometimes you see a flex sign if the CFL ligament ruptures off. This is a pretty dramatic example of that on the right, but usually it's you'll see like a little fleck down here where part of the bone falls off from the CFL. Other things I'm looking at, the talar dome, the shoulders of the talus here, with lateral ankle pain, instability, or following lateral ankle injuries. Sometimes, again, the cartilage kind of gets sheared off depending on the mechanism of injury, which isn't something we're really going to talk about much today. Other things, I always look at the anterior process of the calcaneus as well. You can usually see that pretty well on an oblique and a lateral. This is an ankle film, so you're not going to see it on that. But other things you can do, dynamic ultrasounds are really interesting. I've never done a dynamic ultrasound for something like this. Is it great in theory? Yeah, I'm sure it is. It's probably not easy to find people who can do dynamic ultrasounds. Not really probably the best, or I guess the easiest modality. MRIs for chronic pathology. Typically, we're not really looking at getting an MRI right away. If somebody's complaining of chronic pain, chronic instability, had several ankle sprains over the course of, their adolescence, we can usually jump to getting an MRI pretty quickly. Following acute injuries, though, it would be really unusual for me to order an MRI right off the bat unless somebody had just frank weakness. But the nice thing about the MRI is you can see tendinopathy really well. You can see fluid around the tendon, which is called tenus innovatus. You can see You can see tearing in the tendons. Typically, it's like they're split thickness tears. And usually what you see on MR is the tendon just kind of thinning out. But what I have noticed is the MRIs tend to overshow that a lot, though. A lot of people have thin tendon or attenuated tendons, splitting of the tendons on MR again, and they're not really symptomatic in that area. You can also see SPR ruptures. So tendinopathy. Here's the fibula. Here is, so in this case, the tendon back here, just posterior to the lateral mal, that's the brevis. They're both here. The longest is right here. It's this kind of big, beefier one. Both of them are really supposed to be about the same size. You can see the brevis. It's, kind of wafer shaped here. So that's pretty indicative of like a split thickness tear. You can see some tenosynovitis around the tendon. And then you can kind of see some intrasubstance edema as well. Over here is the opposite ankle. Again, you have some thinning of this tendon here. You have some fluid, within the tendon sheaths. It's probably a little bit more than a physiological amount. This over here could, in theory, be an accessory tendon as well, but I think it's just part of the brevis. So something I was talking about before regarding fibular groove morphology. This is typically what they look like. They're supposed to be at least somewhat concave. They're not always. Most of the really time they're kind of some variation of one of these. This one's completely convex. This is unusual, but it does happen. I have seen it. A lot of the time, when I have people coming in complaining of pain and find that they have peroneal tendon subluxation, usually it's the fibular groove is more flat than anything. But obviously these can all pose problems. Differential diagnoses. A lot of this stuff kind of goes hand in hand. Lateral ankle sprains or chronic lateral ankle instability, fibular stress fractures, sinus tarsi syndrome can kind of present with pain deep within the, in the sinus tarsi and the subtalar joint. A lot of that pain can radiate laterally, and it can kind of mimic some of these symptoms, with the exception of subluxation. So a lot of times people have lateral ankle pain with fibular impingement of the peroneal tendons and like a severe flat foot deformity, whether it's flexible or rigid. Oftentimes, I shouldn't say oftentimes, but sometimes you see people with osteogonum symptoms or syndrome. They complain of kind of deep ankle pain or lateral ankle pain. You get an X-ray and they've got this big osteogonum in the posterior ankle. And they have pain with dorsiflexion, plantar flexion of the FHL, the big toe, and pain to palpation of the posterior ankle joint along that osteogonum. So that's something to be mindful of as well. Sometimes it can be that. Conservative care, you guys are all obviously very, very up to date on conservative care. I know a lot of it probably hasn't changed, but I'm sure, from your standpoint, there's probably a lot more that you guys recommend and do. I know we tend to be pretty much more aggressive with these things than we used to be right off the bat, with the exception of regarding acute injuries where, there's like full ruptures, which again, pretty unusual. Even as people, when you rupture the ATFL or even the CFL, overwhelming majority of people respond really well to aggressive physical therapy. So NSAIDs or NSAIDs, immobilization, tend not to rely on that as a crutch so much. Because again, people just, once you get over that initial period of inflammation and swelling, people just do well if you kind of push them through it, in my experience at least, and get them moving sooner rather than later. In really severe cases, sometimes we put people in a boot, let things calm down, maybe give them a steroid pack to help with the inflammation and the swelling, and then try to get them moving as soon as possible. I love physical therapy for any lateral ankle pathology. Because again, a lot of times that's just what people need. They need to kind of be pushed. They need to be shown how to do things, but they need to kind of work through some of these things more aggressively than sitting around in a boot or a lace-up ankle brace. Indications for surgery. Let's see here, look, we had a question. Would you recommend starting PT in shoes or start immediately with closed chain without shoes? Probably, I don't know if it would make a difference, honestly. I don't know that it would. I think just getting them in the door, whatever you guys are comfortable with doing. I don't know if there's a right or wrong answer for that, but I would I guess the moral of the story is I would get them started sooner rather than later. So surgical options, a lot of different things we do. If I was understanding your question correctly, I hope I was. Back to this. So indications for surgery. Failure of conservative care. Usually not quick to jump to surgery with things like these unless people have frank instability, chronic instability, and severe pain with instability and subluxation of the tendons. Partial tears. Again, a lot of MRs show partial tears. But what I will say with the peroneal tendons, though, a lot of times with these MRs, they don't necessarily look like on MR what they do intraoperatively. Sometimes they look different or more unusual. Chronic pain, incarceration of the tendons, which is unusual but can happen. With subluxation, recurring dislocations, if people are active and it's debilitating and preventing you from doing things, I'm usually pretty quick to to fix something like that. Surgical options, a lot of different things we can do. Anywhere from just a simple debridement or a tenosynovectomy of the tendons, incising the tendon sheath, flushing it out, cleaning it up, debriding the tendon itself, closing back the tendon sheath, direct tendon repairs if needed for split tears. Sometimes you can excise parts of the tendons that are severely diseased without retubularizing the tendons. Tendon transfer is pretty unusual for anything that we've talked about so far. Low-lying muscle bellies. So a lot of times there's an accessory or low-lying muscle or tendon, which differs from low-lying muscle belly. Sometimes the muscle belly sits basically within the fibular groove of the longus or the brevis, and it acts as a space-occupying lesion, and that in and of itself can force the tendons out of the groove. So sometimes when you get in there, there's a bunch of muscle in the fibular groove, and you basically have to debride it or excise it with electrocautery to help make some more space for the tendons. So that's a really important one. Fibular groove deepening, you definitely do that. Again, there's a couple different ways you can do it, which I'll talk about on the next slide, I think. Pretty much all these, when you're looking at the peroneal tendons, you're looking at repairing the SPR, because a lot of times you have to incise it just to get to the peroneal tendons. But a lot of times it's attenuated, it's stretched, it needs to be kind of tightened up anyways. So with the fibular groove deepening, again, historically, sometimes people, what they'll do is they'll just burr off or deepen the groove with a burr. And a lot of times it increases the roughness of the surface of the fibular groove, which I don't have any statistics or evidence that it can lead to further rupture, but just intuitively, it wouldn't be my preferred way to do it. And so what I actually do is I drill from basically the distal tip of the lateral mal up just anterior to the fibular groove and tamp the fibular groove in. That preserves the articular surface on the back. So that works pretty well for me. Tendon debridement, synovectomy we talked about, retinaculum reinforcement, pretty common with pretty much all of these. Sometimes we use anchors, sometimes we use Joe's anchors. I've never done an endoscopic SPR repair. I think it'd be pretty unusual for me to want to do one, just because in most of those things, there's no difference in functional outcomes. If I was doing an isolated SPR repair and nothing else, which also I think would be really unusual, then perhaps I would consider it. But this is just a little peroneal tendinopathy intraoperatively. There's a split tear in the brevis here, which part of it was excised. And then the tendon itself was retubularized here to sit nicely within the fibular groove. So this is what I like to do for fibular groove deepening. Drill from distal to proximal or proximal to distal. It doesn't really matter, just depending on how your access is, with care taken to preserve that articular surface. And then what you do is just kind of tamp it in, deepen it. A lot of times getting accessory muscle belly out or low-lying muscle belly out helps quite a bit as well. You don't necessarily have to, cave in the back of the fibula. You just usually have to make a little bit more room for it. My repairs typically incorporate drilling a couple guide holes into the fibula as well, and for suturing it all back together to reinforce it. And then this last picture over here is basically the peroneal retinaculum covering the peroneals really nicely here. So if you don't fix it nicely, they can herniate through, and then people just have chronic problems. And then you got to go back in. There's a lot of scar tissue. It just doesn't lead to or make for good results. Postoperative protocol. I think when I was in residency, we were probably pretty conservative with these, and I wasn't in residency that long ago. But we were probably having people sometimes non-weight bearing for 6 weeks. Now, honestly, I'm probably getting these people moving in about 4 weeks. With soft tissue procedures, I try to get people moving as quickly as possible. When you're repairing the superior peroneal retinaculum, though, the last thing you want to do is go and rip through your reinforcement. So typically, I have people off these for about 4 weeks. At 4 weeks, they come out of a cast and go into a boot, but they're taking off the boot daily to go up and down gently. They're just performing gentle, active range of motion. I usually try to get people into physical therapy right around that point to get things moving, to reduce, adhesions and scar tissue formation, and to kind of restore the function and the glide of the tendons. So typically, that's when I let you guys take over. From my understanding, and I'm sure you guys obviously do so much that I don't know, so I don't want to go too much into detail about the physical therapy aspect of it and make myself look foolish. But what I try to do is, like I said, I try to get people moving quickly, and that's where I love getting them involved in physical therapy sooner rather than later. The sooner they get moving, the better outcomes people have. I mean, almost always. So typically no real ballistic or high impact activities, until 10 to 12 weeks post-operatively. But other than that, they gradually progress pretty quickly. And then just with outcomes, again, I always have the best outcomes getting people into physical therapy as quickly as possible. Pretty much all of my peroneal tendon surgeries involve an SPR repair. It's just basically inherent to the procedure. Not all of them involve peroneal groove deepenings, but it's, when indicated, I do it. People just do well. Once you get rid of the subluxation, whether it's from low-lying muscle value, whether it's because of the morphology of the fibular groove, or whether it's, from some combination or an injury, once you stabilize it, and sometimes stabilize the lateral ankle as well, people are just so happy. So I love lateral ankle pathology, lateral ankle instability. People do so well with physical therapy. So that's some of the stuff that I really like to do. Obviously, complications, recurrent subluxation is problematic, which is really one of the only reasons of keeping them probably in a cast for, sometimes 4 weeks after surgery. Tendon adhesion or scarring, again, that's why we get them into physical therapy as quickly as possible. Persistent pain, there's no, unfortunately, sometimes people do tend to have chronic persistent pain, usually, significantly better following these types of procedures. Nerve entrapment, unusual, unless you're going a little bit more proximal, but it is possible. And that's really all I have.
Thank you so much.
No problem. And I'm sure it was probably a little fast. I haven't done a presentation like this in a long time. So, and I don't
No, it was great.
Yeah.
Does anyone have any questions you can put in the chat and I can unmute you? Myself, my one thing is I treat a lot of dancers. So the dancers are always doing that ankle circle that you were talking about and snapping that tendon. And I typically will tell them, it's instability, but if they're not having pain, then we really just focus on strengthening with it.
Totally agree.
But when I'm trying to, like you had said, differentiate with os trigonum, do you feel like they do go hand in hand though? Like if they have an os trigonum, they do tend to have some tightness and issues with the peroneal, or
no,
or not?
I've never personally noticed that.
Okay,
it's just it's just the point of that is just to sometimes these things can be easily confused for something else.
Yeah, and that's exactly what I was asking. So got it. Thank you.
No problem.
Anybody else? All right. Well, if not, thank you again so much for joining us.
Yeah, absolutely. Thanks for having me.
And yeah, anytime you have an interesting case or something that you want to present again, feel free to let us know. Hold on one second here. I'm gonna make sure other people are good here in case they wanted to comment. There we go. There's a couple people that were not able to respond, so I want to make sure they had a chance here. But yeah, so if you have any exciting cases or anything like that, let us know, and we would love to have you again and learn more about the lateral ankle.
Yeah, absolutely. Appreciate it.
All right, thank you.
Thank you.